we'll be starting our session soon, Dr. Bhaskar. Usually we have 50 to 80 participants in each of our lecture session. So, and we usually start by 8:05. So I'll be starting soon, and I would like to welcome all of my participants to PSA lecture series. They have been a part of our series for the past 2.5 years now. And we are grateful to Dr. Arun Bhaskar. We welcome you from the platform of Pakistan Society of Anesthesiologists, Karachi chapter. Dr. Arun Bhaskar is a renowned pain physician from NHS UK, as you can see on the slide, as and he's currently chairing the UK section of the World Institute of Pain. He's also the advisor to the National Institute of Health and Care Excellence on the interventional procedures and cancer pain. Dr. Bhaskar is an examiner for the European Diploma in Medicine, Pain Medicine, and FIP examination of the World Institute of Pain, as many of you be knowing that. He's the immediate past president of the British Pain Society and an active member and training of the Neuromodulation Society of Britain and Ireland. Additionally, Dr. Bhaskar is also on the editorial board of the Journal of Observational Pain Medicine and section editor on the cancer pain. This is the minimum introduction which I can give of Dr. Arun Bhaskar. We profoundly welcome Dr. Bhaskar tonight, and we are looking forward to your talk. You may please proceed, Dr. Bhaskar.
Thank you, Dr. Asma, for your kind introduction. I know some of the names that are coming up. Jamil Bhai just messaged me. This is very much a theoretical talk based on what's the published evidence and how we made it together into various guidances. I'm going to show my disclosures. And the reason I put up is that, as Dr. Asma said, I'm involved with a few things which I've been involved with the international group on various guidelines development for back pain and neck pain. And now we're doing it for the sacroiliac pain as well. But I'm also giving an opinion on how to interpret some of these things. So when you look at the guidances, I'm going to start with the nice guidance on low back pain and sciatica in 2016. Because the 2009 guidance that came before that basically said you do physiotherapy, and if that doesn't work, go for spinal fusion. So that created a lot of problems. The then president of the British Pain Society literally got kicked out. And I don't think he deserved that, but that's what happened in the end. Obviously, this was where you looked at assessment and then look at radio frequency, which was recommended. More recently, there were other guidances that has come out. And again, you can compare with the management in various parts of the world. You also have got WHO coming out with the guidelines in 2023 December. The problem with WHO guideline, as with the WHO pain ladder, is that it's pretty much basic. And I'm being very kind to them when I say that. But then their argument is that this is for primary and community care setting. But then the big push is that most back pain should be managed in the community setting, which makes an interesting choice. I just want to go through some of the key facts in the WHO publication. And statistically, you can see that the number of cases are bound to increase in the next 30 years from 619 million to almost 850 million. And it's the single leading cause of disability worldwide. And most people would improve with rehabilitation. It can happen at any age, but elderly people will affect more. And most of us who walk on 2 feet will get back pain at some point in our life. It goes up to about 80 years, but the biggest morbidity is between the age of 50 to 55, and it's more prone in women. I don't like the word non-specific low back pain simply because all it says is it's the pain between the lower aspect of your rib cage to the upper aspect of your pelvis. And it also, this is my opinion, is that if I tell you that, oh, what is my diagnosis, doctor? Oh, you got fever or you got cough. or you got chest pain. It means nothing unless you identify a specific mechanism of pain. And a lot of the back pain you can manage, it gets better, it's fine. But we in pain clinics, we see them at least 3 months or longer. In fact, in the UK, by the time they come to a pain specialist, they've probably seen orthopedic surgeons, neurosurgeons, multiple physiotherapists, and other doctors. It defeats the purpose. This is Australian publication, came out again around the same time in 2022. And again, it's a reasonably good document. But I'm going to talk about this one, because I've been involved in this, and it's one of the most detailed publication, I would say, in terms of the amount of literature we looked into was quite robust. And I was also involved in the publication for the cervical spine. And again, we followed the same procedure. As you would see, most of the authors are similar. Manjukanti and group brought out a publication based on the American Society of Interventional Pain Physicians, but I'm not going to go into the details of it because, as I said, I was involved in the other two publications, and I want to base my talk on that. ASPEN, which is American Society of Pain and Neurosciences, they brought on evidence-based treatment with guidelines fairly similar in 2022. Again, a reasonably good quality publication. So what I want to talk about is, how did we develop these consensus practice guidelines so that you understand the process that's involved? What are the important recommendations that are relevant to clinical practice? I want to look into facet joint procedures that would need further research and how we manage it, because vast majority of the back pain we're dealing with is from the posterior segment. But before we go down that, the thing that is very fashionable these days, particularly in the US, is management of vertebrogenic pain, which is in the anterior compartment. So again, ASPEN has brought down a best practice guidelines on vertebrogenic pain. And again, quite well published, even though it's still early days, they have done a good job, and some really good practical tips have been mentioned in that. How do you diagnose it based on clinical presentation? But the treatment is very much based on imaging that shows type 1 and type 2 modic changes, end plate damage, presence of active Smoltz nodes. And then if a SPECT CT shows increased radiotracer uptake and CT shows degenerative end plate changes, you are a suitable candidate for basivertebral nerve ablation. The idea being is that the basivertebral nerve is the one that is supplying the vertebral body and the end plate, which is the source of the pain. The downside is that we don't have a diagnostic tool. We can't do a diagnostic block. Now, there is an argument that you can do discography above and below to see whether that would help. It's a surrogate marker. We are dealing with vertebrogenic pain and not discogenic pain. And we have almost moved away from doing discographies because if you put enough pressure inside the disc, it's going to hurt, even if it's a normal disc. And there has been a lot of false positives. So the idea is that anyone who does vertebroplasty or a kyphoplasty will know you can go through the pedicle into the vertebral body, and then you're doing a radiofrequency lesioning with a special kit to ablate the nerve. As you can see, you can get this little cavity forming. And what I've always questioned is the duration of effect. And 12 to 18 months, people talk about it. And the problem that happens is that what are you going to do after that? You can't repeat the procedure, and it's not going to be much benefit. If it's in a different level, we can do that. On the same level, I ask colleagues in the US, and the usual answer is, well, then they will probably end up with a spinal cord stimulator. And my question to them would be, then why didn't you do the spinal cord stimulator and save some money? Okay, I don't want to get into the controversies of that. Let's talk about radiofrequency. Now, lumbar radiofrequency is probably bread and butter stuff for most pain doctors. But doing it properly is important, and I'll show you why. You can say that the lumbar ones I showed you and the cervical ones, these are reasonably good positions. good practice says that don't go too far anterior, but you need to get about a centimeter, and you use 18 gauge cannulas these days. I'm going to show you a picture of a very famous doctor. I walked past his theater in the private hospital, and this is the picture I saw. 5 levels. And then I got the lateral view from the radiographer afterwards when he said, well, you push it much more deeper than this doctor. And that's his picture. Now, the only good thing about this picture is it's a very good lateral view. Your target area is there. You're nowhere near the target, and it will not work. Nobody will blame the practitioner. We have a tendency to blame the procedure. So if you don't do the procedure properly, you're not going to get the outcome. And causes of failure for interventions is wrong diagnosis, wrong target, failing to hit the target, or hitting multiple targets, like a cervical epidural, and then it works, but short term. How do we do it long term? There is this publication by Ala Abdel Said, which looked at who is doing the procedure as an international survey, mainly in the US. And their summary was that a significant portion of practitioners who perform lumbar radiofrequency do not have pain fellowship training at an accredited institution or do not maintain current board certification. Now, if you are not trained and if you don't do it properly, if you don't get the right outcome, you blame the procedure, not the quality of how it was done. So let's go back to the guidelines. And the guideline is aimed to show people that you need to follow certain practices to get your best outcome. The reason we had to create this group was there were a lot of controversial issues. It's one of the commonest medical procedures. And some organizations like Spinal Intervention Society had very strict diagnostic criteria. So we had a lot of false negatives. But mainly, healthcare funders were questioning it. Part of the reason was this study. The MIN study from the Netherlands came out, and it really, in 2017, it set the cat amongst the pigeons. The problem was that rather than do parallel placement of the cannula, their technique was the perpendicular technique. I deliberately put this picture from Professor Nath because this was how they started with the old machine. And at that time, they were doing it like that. But we moved away from this, mainly due to Dr. Nath's work, that this is the right approach to get good lesion. And we will discuss this further. The second issue is that they were doing it at one level. Now, we all know that every facet joint gets nerve supply from 2 levels. So you need to target 2 medial branches to actually denervate the joint. And if you don't do that, and if you only do it at one level, you're not going to get the outcome. So this was not there in the study. They were only doing one level. And then the third bit they did was that they were combining lumbar fasciogenic problems with people who have got sacroiliac problems and also discogenic pain. So it was a very non-specific cohort of patients. So this guidelines group was represented by various organizations, predominantly from the US. From the UK, I represented British Pain Society. Jan van Sundert came from the World Institute of Pain from the Netherlands. Then Korean Pain Society was involved, and Canadian Pain Society was involved. And it was a very comprehensive group. We were looking at various questions ranging from history to diagnostic blocks to our radiofrequency, technical aspects of how we do the blocks and the radiofrequency, how do we mitigate complications. 17 questions we asked. For the cervical one, we did 20 questions, much more in detail for the risks involved due to the vascular structures nearby, etc. So we did a very extensive PubMed and Embase and Google Scholar and Cochrane review. We then had a modified Delphi technique that went through 3 rounds where we answered the questions, evaluated the response, revised the question again, revised the responses twice, and then the final responses were put into the recommendation. So it was a fairly robust and comprehensive process, which is why we called it as a consensus opinion, but it is based on solid published evidence. We graded the level based on how we defined, where we level A, B, and C, we use it as offer to provide for A, B, and C, and in C, you do it based on individual circumstances. D recommendation means don't use it at all. And then based on the quality of evidence and the number of studies and the size of the study, we rated it as high, moderate, and low. Now, this picture is very, very important. We omitted patients who had radicular pain, whether it is sciatica or cervical brachialgia. What we were looking for is patients with specific facetogenic pain, but they would have referred pain. The problem we have is to identify this is not almost straightforward. We had to be very careful in how these patients were selected in their studies. Now, can you use history and physical examination to identify painful facet joints to select patients for blocks? And the answer was that even though paraspinal tenderness and some lack of radicular symptomatology could be a weak predictor, no specific history or examination can reliably predict whether they would have a positive or a negative block. What we can do is to identify the level of pain, the side of pain. Based on the pain patterns, we can select whether it is posterior problems or an anterior problem. Grade C evidence with low level of certainty. So what about radiological findings? Will that show any specificity in terms of prognostic blocks or radiofrequency outcomes? And again, the Cohen paper that there is no association between the presence of significant facet joint pathology on MRI and results of denervation. In terms of CT or MRI before blocks, it's mainly to identify red flags. It doesn't show what is causing the pain. There is some evidence to show that in cervical facetogenic pain, but it is very insufficient evidence. And the only way we talk about why we need imaging is to reduce complications. You do not want to miss a cancer. You do not want to miss an osteoporotic fracture, etc. So the bottom line is very simple. We do not do spinal procedures without image guidance. Gone are the days where we can do it blindly, because most of the time, when people used to do blindly, they were putting very large volumes and hope it hits something. The second bit, again, is the proximity of vascular structures, particularly in cervical spine, and to also precisely identify our target areas so that we get the best outcome. Digital subtraction angiography has demonstrated that there is far more vascular uptake than we think when you do it on fluoroscopy alone. But then most practical purposes, we don't do digital subtraction angiography. The other thing you need to be very aware of it is a negative aspiration does not mean that we are not in the vessel. Most of these vessels, as you can see from this picture, they're very small vessels. When you aspirate it, the vessel will collapse if it's away, and you won't get any blood. But when you inject, you can inject intravascularly. Now, we know that we do not use particulate steroids, especially in cervical spine, for the same reason. When you do ultrasound, ultrasound can tell you the vascular structure, but then again, the quality of imaging on ultrasound guidance alone is not as reliable as in fluoroscopy, unless you are in really good hands. There are colleagues who are very good with ultrasound, but most pain doctors who have trained with fluoro have got they have their reservations with using ultrasound. Secondly, you cannot identify flow patterns on ultrasound alone. So image guidance, whether it is fluoroscopy or CT, for lumbar middle branch block and intra-articular injection, you got low-level certainty grade C evidence. For radiofrequency for lumbar and cervical, you got grade B, low or moderate level of certainty. With cervical middle branch block with ultrasound or fluoroscopy, you've got moderate level of certainty. And cervical intra-articular, which we don't do that many, it's a low level certainty. So definitely the evidence is much stronger for cervical middle branch block. Now, do you do medial branch blocks or intra-articular injection? And the Cohen study showed very clearly that there is higher success for radiofrequency following middle branch block rather than intra-articular injections, even though the statistical difference was only about 10%. But what we are doing with middle branch block is that we are trying to mimic the lesion we are doing with radiofrequency. So middle branch block is the prognostic injection of choice. We've got intra-articular injection, which can be done in patients you do not want to do radiofrequency for whatever reason. Grade C evidence is there. The recommendation from our group was that we do not routinely use intra-articular injections for diagnostic purposes, and we do not use steroids for middle branch blocks. Now, what's the percentage or what's the probability cutoff for sensitivity and specificity? Now, spinal intervention society is operating at a much higher standard, and they were looking at 75 to 80% improvement in pain, whereas in for all practical purpose, we feel that 50% pain relief is a good balance between sensitivity and specificity. So if you get 50% improvement in pain following a diagnostic middle branch block, it's considered as positive. And then the question is, how many blocks do we do? The cutoff we said was that there are several studies that shows no diagnostic block, one diagnostic block, or two diagnostic blocks. And actually, the more you do, you will find that in the research setting, some people would want double blocks, but for all clinical practice, single block is more than enough. So effectively, the recommendation was you would like to see 50% reduction in intensity of pain after a diagnostic middle branch block, and a single prognostic block is enough. But remember, for every joint, it needs to cover 2 levels for middle branch. What is the ideal volume that is used? And we looked at several studies ranging from 0.25 mils to 0.5 mils. The idea being is that the more volume you put in, you are more likely for it to go somewhere else. And particularly in cervical spine, the smaller the volume, the more specific it would be. In the lumbar, they were talking about, again, no more than 0.5 mils. And if you're going to do intra-articular injection, 1.5 mil. But a lot of cases, we know that 1.5 mil can cause either capsular rupture. If not, it will probably end up in the epidural space. So we just need to be very cautious about the volumes we put in. So the ideal volume was for lumbar, we recommended 0.5 mils or less. In cervical middle branch block, we recommended 0.3 mils or less. It gives you more specificity and sensitivity. What about how do we mitigate complications? The most common thing was inadvertent vascular uptake. And again, aspiration, 1/3 of the cases will not detect intravascular injection under live fluoro. And if you look at the live fluoroscopy, 11% showed inadvertent vascular uptake. And when you look at DSA, it uncovered another 7.8%. Almost 1 in 5 cases showed vascular uptake, which is why the recommendation for non-particulate steroid injection. Do we put contrast media prior to medial branch block? My answer is no, I don't routinely do that, mainly because it's time consuming. But if you are going to do any clinical study, then it may have a case. Also, if you don't get it in the right place, you will struggle to see where you are going next. But Spine Intervention Society recommends use of contrast. The other reason why we say contrast may have value is to rule out intravascular uptake. Now, there is another aspect of it. If you are injecting it intravascular, you can get a negative diagnostic block because the local anesthetic is no longer around the nerve, the middle branch, it is actually inside the vein. So what you do is you need to have real-time fluoroscopy with contrast, and you need also negative aspiration to get the best outcome. Do we stop anticoagulants or not? And the recommendation was that for thoracic and lumbar medial branch block and radiofrequency, it's a low-risk procedure. You don't have to stop it. Cervical medial branch and radiofrequency, it's an intermediate risk. It's up to the practitioner. But then, of course, when you do much more complicated procedures, including intrathecal procedures, or if you are doing implantable devices, then, of course, it's a high-risk procedure. So, anticoagulant should be continued in terms of facet joint blocks and radiofrequency, because if it wants to be discontinued, talk to the relevant specialist, particularly if they've got a stent or they are at high risk of stroke. When you do cervical facet joints, make sure that the electrode is in the posterior two-thirds of the lamina rather than go anterior, because you're more likely to damage the vascular structures if you're in the anterior one-third. So in summary, when you do radiofrequency, these are the questions to consider. Do we do unilateral or bilateral? I would never do bilateral in cervical spine. And again, do we do 3 lesions or 2? If you do 3 lesions, 3 levels, you're covering 2 facet joints. Do we sedate? I don't sedate anybody. I should thoroughly recommend you not to sedate for cervical procedures. Do we stimulate? Again, there is some evidence that motor stimulation would provide added safety. Sensory stimulation is very painful, but even for motor stimulation, we can give local anesthetic, which means that you are going to make it painful when the muscle twitch. Is there a role for pulse radiofrequency in managing facet joint pain? This guidance didn't cover that. And then how do we do radiofrequency if they have particular screws or other metal work? We can use techniques like Kuldar for bipolar lesioning. Again, this was not covered in this document. How soon do we repeat radiofrequency? And this was an interesting discussion, because how long does it take for the neurons to regenerate and pain to come back? The Americans were much more happy to repeat every 3 months, ideally up to twice a year, so pain relief should be 6 months or more. We felt that in Europe, I think we accept at least we need 12 months, ideally 16 to 18 months or longer. So good technique makes a big difference. Now, what is more important is that the success rate of repeated radiofrequency can decrease between successive procedures, but the pain relief still remains above 50%. Depends on the studies, but if you're getting more than 50% pain relief, you are very likely to improve the quality of life. Do we do bilateral cervical? And it is. So the recommendation says that bilateral medial branch may be performed at 1 session, but avoid bilateral radiofrequency. And again, treating two spinal levels during one session should not be run routinely if you're doing bilaterally. And I would strongly recommend not to do bilateral if you're doing C2, C3, C4 levels, because you will get a floppy head and it's too dangerous, and it will be very difficult to defend it medico-legally. So I'm just going to go through the questions, some of the other questions that we haven't covered so far. Do you do physiotherapy and conservative treatment before we go for a prognostic block, whether it's middle branch block or facet joint blocks? And there's a low level certainty that a 3-month trial of conservative management is not unrealistic. You can try physiotherapy, exercise, massage, tense acupuncture, and also simple analgesics. What's the effect of sedation on the accuracy of diagnostic or prognostic blocks? Again, most of the current guidelines says sedation should not be used unless there is very specific individual indications. There's a high risk of false positives in sedated patients, particularly if you're going to use fentanyl or any drug that is an analgesic. If you are to give sedation, patient should be conscious and able to communicate. How many blocks? So it says that single diagnostic block is enough. More than one block may improve success, but also it can also deny people who will benefit from radiofrequency because you can get false negatives. Again, low to moderate level of certainty. Do larger lesions make improved outcome measures? Okay, and how can we increase the size? Now, if you think about how to increase the size, if you use larger electrodes, and especially, we are going to 18 gauge and even 16 gauges, we use curved needles, proper orientation of the electrodes, which I'll come to, higher temperature, longer time, and fluid modulation. All of this can make large lesions. Now, what we found was that a larger lesion will capture the nerve, but there is low level of certainty whether the large lesion will increase duration of effect. If you have done a good lesion around the around the nerve, you can still get good duration. But if you use bigger lesions, you're more likely to make sure that you capture the nerve. Case in point, you can have, if you look at the difference, 22 gauge, 20 gauge with slightly bigger active tip, and that's an 18 gauge with a curved needle. And that's a bipolar lesion, that's a unipolar lesion, that's we are using the sacroiliac denervation system, which makes really big lesions. Orientation of your needle. Now, we know that we should not be using perpendicular placement because you can only get a point electrode. Parallel placement was what was recommended, but now we use curved needles, but if you, which will cover a wider area, and you can make one lesion like this and a second lesion like that, and you will get better outcomes. If you don't have curved needles, you can actually orientate your straight needle at an angle, about 10 to 15 degree angle to the nerve, and you are getting a bigger capture of the nerve when you do that. Stimulation we mentioned.
बंदे तो आए थे काम के लिए
I would request all the participants to please mute yourself.
Yeah, thank you. Thank you, Dr. Asma. So do we do sensory or motor stimulation? Now, motor stimulation, there is some evidence to show that it can be beneficial for safety and efficacy, but A, it is painful for the patient, and B, if you do motor stimulation, you got to pull back to give local, and then you got to push it back in. If you do develop a neurological problem, you again will find it difficult to defend. So good positioning with better imaging is probably more sensitive. If you are using a single lesion, particularly with a perpendicular placement, as they did in the main trial, sensory stimulation has some benefit. But if you're doing multiple lesions, you don't need to locate the nerve. You're making large lesions or multiple lesions. You are bound to capture anyway. And that has got grade 1 level of evidence. What about complications? Again, Complications are usually because of bad practice, bad technique, or not listening to the warning signs. Major complications, particularly with severe neurological problems, happened in patients who were sedated. So that's one thing. The other things were intravascular injection. We know that patients where anticoagulants have been discontinued have developed either cardiovascular or cerebrovascular complications. If you do cause a nerve root injury, that is only explained by bad technique and bad imaging. Patients with pacemakers and implantable defibrillators have problems. If you do multi-level denervation, that's why when you do L2, L3, L4, L5, you're completely denervating your multifidus muscle and you get paraspinal muscle degeneration. So you can do it for your diagnostic block to relax the muscle completely. But ideally, if you want to do denervation, you're better off doing only 3 levels. You can cause burns from poor placement of the grounding pad, and patients who have had spinal surgery are less likely to have benefit from radiofrequency. So the recommendations for future research was divided into major areas and minor areas. The idea was to make it more safer and effective. We are doing some work with high intensity focused ultrasound to see whether we can do it non-invasively. We need to find out whether we can prolong the benefit by injecting nerve inhibition factors. We need better tools like biomarkers or better imaging to identify painful joints, and then look at predictive modeling tools to identify better prognosis and outcome. And there is a role for regenerative therapy that is being looked into, where we can reverse the aging process of arthritic joints. The minor areas were, how can we target nerves by real-time electromyography or more reliable techniques in stimulation? How can we prevent complications, particularly nerve injury? Is there any non-ablative treatments we can do, or non-invasive treatments even? And how can we look at better selection criteria? And how can we improve the precision of diagnostic blocks? So these were the summary of recommendations which I've just elucidated. And to summarize, you need to make a correct diagnosis of facet joint pain. You can do all the clinical investigations and radiological, but the best way to diagnose it would be a small volume, precise diagnostic middle branch block. You can, if the patient is uncertain on the side, you can do it bilateral, but try to do the denervation one side. It's far more reliable. Larger lesion size can be done with 18 or 16 gauge cannula with a curved active tip. I don't agree using steroids post radiofrequency. The recommendation says that if there's high risk of developing neuritis, you can do it. But I always ask the question, how many neuritis have you seen? And we want the inflammatory effect of thermal RF to get longer benefit, bigger lesion size. Putting steroids in can reduce it because it's a very potent anti-inflammatory. It's also a very potent immunosuppressant. Hence, doing after pulsed RF also reduces its effect. You should warn about flare-up after radiofrequency, and the effect could take a few weeks. Make sure that the patient is mobilizing. You should always remember that there is more than one mechanism for pain, particularly when it's chronic back pain, and you got to rule out other causes. Some recommendations summary for cervical spine. Again, no historical or examination signs to show response to blocks. Always try and do conservative management for at least 6 weeks before you start jumping in with interventions, because a lot of the pain would settle down and the risk for an intervention is much higher in cervical spine than in lumbar spine. There is no prognostic indicator between radiological image and radiofrequency or blocks. Imaging guidance is very important. You need to look at the lateral approach as a safer option for C3 to C7. We can, when we do cadaver workshops in future, we will go through these minutiae about these things. You need a posterior or oblique approach for C8 middle branch block. Small volume at 0.3 mils, minimum 50% pain relief. Single block is enough. Don't do bilateral radiofrequency. If you are brave enough, you can do bilateral middle branch block. But again, I wouldn't recommend it. We mentioned about parallel or near parallel placement or curve needle. Larger lesions are more likely to improve your outcome. Stimulation, we discussed it. If you want to do intraarticular injections in the neck, no more than 1 mil, you will leak out of the joint. Only use non-particulate steroids. And I'm very recently, a very senior colleague of ours did a cervical procedure and patients paralyzed. It's very difficult to defend such cases. So anything in the upper thoracic or cervical, always use non-particulate steroids. I'll stop here. Thank you.
Thank you so much, Dr. Arun Bhaskar, for the very focused and targeted talk on the spinal pain. I'm sure that most of the participants who are here, they have a background of pain management. So I can see some of the few of the pain consultants over here. I would request all of my participants to kindly ask either by unmuting their mic or by asking on the chat box so that we can follow the questions and answers afterwards.
Assalamu alaikum. This is Dr. Jamil Sabit from Lahore.
Hi,
Welcome,
Jamil
Dr.
bhai.
Jamil.
How are you?
Fine. Dr. Arun is my old friend and colleague, and it is really exciting to see him today with us. And this was really a scholarly a lecture on the facet joints, and you have covered almost everything in this. I appreciate. And the important thing which you have also mentioned, that the proper training is very important to do any interventions around the spine especially. And I appreciate that you joined us for this on this forum, and we hope you'll again join us, especially on the other aspect.
Hopefully, yeah, definitely. I mean, as you know, I've already made a lifelong commitment. I've been visiting every year, and with this initiative with Dr. Asma is doing, hopefully I'll be visiting more frequently.
Yeah. That's wonderful. That's really wonderful. So
Dr.
hopefully we'll
Jamil,
see
we are expecting to have Dr. Arun Bhaskar very soon in Pakistan as well, and we are so happy and we are so excited that we are having him on our forum from Pakistan Society of Anesthesiology lecture series, because many of the aspiring pain physicians or those who want to pursue their career in pain, I'm sure that they will be gaining more experience from Dr. Arun later on, when we will have more talks of him on regarding, examination conduction and rest of the things.
Perfect.
So I would like to ask one question from you, Dr. Jamil, that as Dr. Arun Bhaskar has just mentioned about the facet joints, in your experience, how many of the facet joints, the cervical facet joints, because right now we are not talking about the lumbar facet joints. So in your experience, have you seen any complication in the cervical spine facet joint injections, or what are the other complications or difficult to treat patients have you ever seen in your experience?
Yes, when I started my intervention in 2007-8, I didn't have the radiofrequency machine with me. So that time I was simply doing periarticular or some cervical intraarticular injections. But the volume was very important, as he told, that 0.5 maximum I was using that time. And later on, I had radiofrequency available with me. And in the initially in one patient, when I did this cervical RFA, one patient, he developed some neuritis, and especially I think I hit his one motor nerve also. So he had post procedure pain in his arm also. He developed that, which was not present before. So I'm telling all these things because proper placement of the needles and proper stimulation, especially for the motor stimulation, is very important, especially when you do RFA for the facets, because in the cervical area, you don't know, this is only the case of millimeters that you can heat the motor nerve also. So this is what I found in my career. And later on, Sorry.
Sorry.
Yes, please.
So just cutting you off on that to ask Dr. Arun Bhaskar. So Dr. Arun, as Dr. Jamil Sabir has just mentioned that the use of neuromuscular monitoring might be important in such cases. In your experience and according to your guidelines and the literature search and your extensive work into these joint blocks, what is the recommendation and how would you see it otherwise?
No, I think Jamil Bhai made a very relevant point. The whole idea of doing motor stimulation is to prevent the needle proximity to the nerve root. Okay, but if you look at a patient and you stimulate the medial branch, the multifidus, in the lumbar, the multifidus will twitch. In the C-spine, the paraspinal muscle will twitch. Okay, how would you differentiate between that and a nerve root twitch? Okay, that is one point. Secondly, you cannot give local anesthetic until you put the needle in the right place. Now, we are recommending people not to use sedation. So it's not very pleasant for the patient, especially when you have got severe pain. What you really need, I will come to the C-spine. And again, this is something we have, Jamil Bhai and we were together as faculty in various forums, both in Pakistan and in outside Pakistan. And this is what we teach. One of the things I would say is, let's talk about lumbar spine first, then I'll come to the cervical spine. You need 3 views. And again, the lateral view, even though in FIPP we say do it, most people are not lying properly to get a lateral. Secondly, if you have a big belly, and most people with big belly has got back pain, you will never get a true lateral. What you need is what we call as a superior view, where we are actually angling it cephalad and looking at from the top. And you can see that your needle doesn't go, there's a slight space between the edge and back. And that is, you will not be anywhere near the nerve root, number one. And number two is that in the C-spine, this is the advantage of doing it in the lateral position. Always remember that the nerve, so vascular injury will not happen because the nerve root is between the vertebral artery and your needle tip. So you have to really puncture the nerve root and the patient will scream. You got to be very bad in your technique to do that. What I tend to do is I don't give too much local anesthetic. I give about a mil before I do the radio frequency. The advantage is that you can they will still feel some heat or pain, but not too much. What I tell the patient when I do the C-spine is, you keep talking about something. Usually I ask about the holiday. So they talk. So we know that the posterior circulation is intact because they will have, at least in theory, if something happens with vertebral artery spasm, they will have slurring of speech or something. We can stop immediately. But also, when it happens, they'll say, I can feel it. I can feel it. If you ask them, is it shooting down the arm? And if it is not shooting down the arm, you know that the radicular aspect is feeling it, but it's not being lesioned. So there are safety mechanisms, but good imaging is the key. Because the problem with the motor stimulation is that, and as I said, it's very safe. Jamil Bhai's point is perfect, but once you stimulate, you got to pull back to give local. You can't give local in front. You got to give it pull back, and then you got to push it back in again. And if your imaging doesn't correspond, a millimeter can make a difference. So I think the main thing is that you should be able to communicate with the patient to make sure that it is in the case. And you can ask the patient, you do it and patient says, I'm feeling down. You ask the patient to move the leg or move the arm. And I think the more you do, the better you become. The other point I want to make in cervical spine, what I do for all practical purposes, pain is mainly in the neck and down the arm, shoulder. The main lesion would be either 4, 5, 6 or 5, 6, 7, depending on how it is. If they are complaining predominantly of neck pain and headache, you ask them whether they have pain here. If they say yes, then it is C2, C3, C4 and third occipital. If there is no pain there, it is C2, C3 and third occipital. So you are not blindly doing 5 levels or anything. And that's another reason why I don't like doing bilateral. Because most facetogenic pain, be it cervical or lumbar, is usually unilateral, and then you start compensating with the other side. So
Yeah, that's right.
in lumbar, you can do bilateral just to check which side is the dominant pain side. But
Right.
cervical, you don't need it.
Right. So, Dr. Jamil, you can continue from there. I'm sorry, I just pointed it out because it was a very important point as mentioned by you and as explained by Dr. Arun. Please continue.
Well, actually, Dr. Arun very nicely told everything, Alhamdulillah. And I don't need to talk more on it because it was really wonderful. And he refreshed many of my things also. And it was really
I don't think
wonderful.
I don't think there is a huge difference in your practice and mine. I think we do exactly the same thing.
No. You are doing very wonderful things. You are doing much better things than us. And we have
I'm not sure about that, Jamil bhai. The only
No.
difference is that you do it in Pakistan, I do it in London. The only difference.
There is a lot of difference.
मेरा पेशेंट ज्यादातर गोरे है, आपका पेशेंट ज्यादातर पाकिस्तानी है, वही फर्क है और कुछ नहीं है.
Right. So we have, thank you so much, Dr. Jamil. So we have other seniors as well. I would request
Yes.
other pain physicians who are present here. Let me just check out. Dr. Tahir Akbar is here. Dr. Tahir, would you like to comment or share your experience here with Dr. Arun and us?
Thank you very much, Dr. Asma. Thank you, Dr. Bhaskar. It was really wonderful.
Thank you, sir.
talk. I really thoroughly enjoyed it. Most welcome. You had been to Pakistan multiple times, but again, welcome online to Pakistan community.
I am planning to come again multiple times.
Yes,
This is just the beginning.
You are most
So we
welcome.
won't let you go anywhere else other than coming to
I'm not
Pakistan.
planning to. No, I've already made that commitment. Jamil bhai knows
Yeah.
about it. He was there right from the
Yeah.
beginning. So yeah, I mean, hopefully we'll plan that meeting in February.
Definitely,
Sure.
we shall make
Waiting.
something. And we also have, I'm so sorry, I just have to look at and scroll the
No, please.
participants.
take
We
your time.
also have Dr. Salman Salim here. He's also the presiding member of Society for the Treatment of Pain, Pakistan, STSP. Dr. Salman, please.
Assalamu alaikum. Thank you very much, Dr. Asma, for giving me opportunity to say something. Thank you, Arun Bhaskar. You gave a very wonderful talk here. I have met you in Lahore, cancer pain management. That was also very
I
excellent.
remember you. I remember you from Shaukat Khan.
Thank you, Arun. We wish always that you go on coming Pakistan frequently, and we will welcome you here all the time. And in our next pain conf, I extend my invitation right
Thank you, sir.
now. Thank you very much.
Thank you, Dr. Salman. So I don't think we have more. Okay, now we have a question from Bishoy
yeah, I've
Nassar.
seen-
What is the complication
I've
of
seen that.
steroid after measles? Yeah.
Yeah.
So,
there is no complication as such. I mean, again, the one thing I would say is that we routinely where we are told that we should put steroid after ablation. My theory is that steroids are anti-inflammatory agents and steroids are immunosuppressants. So whether it is thermal RF or pulsed RF, I think that giving steroids will reduce the impact. We won't, people talk about, there is no evidence to say that giving steroids will reduce the pain after the procedure, number one. And people talk about neuritis, and again, Jamil bhai made the point very clearly. His patient developed neuritis because it was a nerve root, not the medial branch. I believe that if you do not give steroids, because my outcome numbers are a lot longer, but because I compared it with colleagues who do steroids, and their outcomes are at best 12 to 18 months. My outcomes are 2.5 years or longer in patients who are mobilizing. And the only okay, I make big lesions, and I do 3 levels, and I don't give steroids, and that's the key. And I think the people say that, oh, the lesion is already made, So the steroid wouldn't make any difference. The steroid doesn't make any difference, and why are you giving it? You talk about, you reduce neuritis, and people talk about it. And I ask the question, how many cases of neuritis have you seen? And they will talk about, oh, I've seen a few. Okay, give me a number. Is it less than 5, less than 10? And these are people who do more than 300 cases a year. So I'm not sure about that.
So, Dr. Arun, I've been also practicing pain for quite some time now. I have seen certain patients with the spinal pain, especially in the cervical region, where upon examination and in the first instance, patients comes to you, and especially when a because most of these patients, they are being referred by our neurosurgeons or neurology colleagues. And at times, even they miss that these are the trigger points in the shoulder or in the neck region, which are mimicking the cervical pain. And they recommend or they refer the patient to us for the facet joint or for the cervical epidural. So do you have, according to the experience you have, do you have any recommendations to especially the younger colleagues on the injection of the facet versus the other steroid injections in the trigger points? And are there any recommendations for that?
Okay, so it's very simply put. I mean, trigger point injections are okay if it is a short-term solution, or you got a muscle spasm, you're relieving the spasm. That the same thing works with acupuncture, same thing works with massage, or whatever you want to call it. Repeated, and for trigger point injections, steroids have no role anyway. And in fact, I've written an article on myofascial pain in cancer patients, and we have demonstrated that steroid has no role there. It's basically that adherence for the muscle to the fascia is what you're trying to treat, and hydrodissection works very well if needed. Vast majority of the spinal pain that is coming, even though it is coming from the muscle, giving a medial branch block will completely relax the muscle. And I would go down that route rather than repeated trigger point injections. The second question in terms of, you mentioned about facet injections versus epidurals. Okay. Now, epidural is for managing radicular pain.
That's
And
right.
there is a role for steroids because either there is inflammation from the disc, or there is an element of neuritis because of the irritation, or you're trying to shrink the fat in the epidural space so that the nerve root has a bit more room around it. So and then you do the flossing exercises so that the nerve root glides, you improve the radicular pain. Other than that, there's no role for steroids. So diagnostic middle branch block, no need to use steroids. Facet joint injection, again, if it is an active patient, I would go for middle branch block and radiofrequency rather than intra-articular facet. If you don't have radiofrequency, by all means, do it. But then again, be careful. How many times a year are you going to put steroids? Elderly patients, you're going to develop osteoporosis. I'm just going to answer a couple of questions. I think Dr. Jamal Humayun has mentioned about the volume. Ideally, we do it for diagnostic middle branch block. Therapeutic block, we don't recommend middle branch block as a therapeutic block unless you got a very active patient, an athlete, or somebody who needs something to do that stretching. That's fine. But most the therapeutic injections we talk are intra-articular. Dr. Shahid Dar has mentioned about basivertebral block if chemical neurolysis. You got to be very careful when you are putting chemical inside the bone, because these vertebral body, particularly anyone who is past the age of 45, vertebral body and after ileum and sternum, vertebral body is the biggest source of your RBCs. Now, if you are putting, and it's very vascular area, and you have the basivertebral plexus of vein also, if you put a chemical in and that venous system takes it to your brainstem, you can have problems. I would not recommend that. I think it is dangerous. You can put cement in, you can put bone cement in like you do in vertebroplasty. You get the same neurolytic effect without that risk. Dr. Shahidar has also asked about the role of dextrose in trigger point injection. I don't have any experience. I think people have used hydrodissection as part of prolotherapy. I don't have experience in that, so I don't want to comment on it. But I will tell you that dextrose injection is not pleasant. It's painful. So I don't have the experience to comment on that. I'm not a big believer of repeated trigger point injections. I don't mind doing a trigger point injection to relax the muscle so that, if somebody comes with a neck like that and it's muscle spasm, you can deal with that. But in terms of managing chronic condition, I would rather look at a bit more sustainable option where you can do a diagnostic procedure, confirm, and then do something more definitive. I hope that answers
Right.
that question.
I think it does. Thank you so much. Do we have any more questions? And I think we are just on time in finishing this talk. Wonderful talk. And we are really grateful from the Pakistan Society of Anesthesia Karachi chapter that you accepted our invitation, and you're here at your peak time, which is 3 p.m. in UK.
My pleasure.
So
No, it's okay.
really grateful to you, and we looking forward to have you more on this forum as well as on another forums from Pakistan. Thank you so much,
We
and
will
thank you
continue to
everyone
collaborate.
for joining us tonight. Definitely, we do share the feedback forms. Kindly fill in the feedback form to get the e-certificates. Really obliged. Thank you so much, and have a good night. Thank you.
Thank you. Thank you very much. Bye-bye.
Thank you. Thank you, Dr. Arun.